Hi everyone. Please join me in welcoming our distinguished guests for our next session. We have here with us Avantika Dhingra and Dr. Aparna Sharma, who we have here for the next session to delve deeper about the exploration of women's leadership in public health. Avantika is the program lead at Women Lift Health, and her prior roles include being a senior manager at CLOP and senior project manager at Central Square Foundation, where she focused on improving classroom instruction and practice for foundational learning. She has also been a Pyramid fellow in the past. Additionally, we also have Dr. Aparna, who is a professor at the Department of Obstetrics and Gynecology at All India Institute of Medical Sciences, New Delhi, and she is also associated with Women Lift Health. Please give them a big round of applause.
Hi, everybody. We know it's the end of the day, and it's also, and we can see the rooms emptying out, but try and stay back, and we'll try to make it as interactive as possible. I'm Avantika from Women Lift Health. For those of you who don't know what we do, we're an organization that tries to expand the power and influence that women have in mid to senior level positions in public health. And I think the premise with which we work is that issues in public health will not be solved if we don't have women on decision-making tables. And for that, we run a one-year leadership journey where we provide the tools and resources for the women to essentially get there. And so Aparna was one of our alumni as part of the first cohort that we ran for women in public health. And as she was introduced, she has been at AIMS as a professor in the Department of Obstetrics and Gynecology, and was also a pretty fantastic fellow as part of the leadership journey. So without any further ado, I'm just going to start our conversation. Why don't you tell us, Aparna, a little bit about your current work, and if you could also focus a little bit about what does it mean to be a woman for the kind of work that you do.
So, very good evening to all of you, and thank you, Avantika, for having me here today, and thank you, Path. So, first of all, I think evening time, all of you really want to get away, but really nice to be here, and I've been hearing about the pitches that you put forth, and very interesting. So, essentially, just to give you a background of my work, so I'm an obstetrician. I conduct deliveries to begin with. But I specialize in something called maternal and fetal medicine, which is actually treating the unborn child. And this is actually very exciting because what I do is called fetal therapy. So I don't know, some of you must have heard very recently that, we give blood to the unborn baby through the maternal placenta. So for that, we got blood from Japan, or maybe we do surgeries inside the mother's womb. So this is very exciting, innovative field, and we provide opportunities for the babies who are, unborn to be born and have a healthy life. So what I do is quite exciting, very challenging, very stressful, but I really love that part. So that's called maternal fetal medicine. And Dr. Nikhil Tandon sir is my professor. So really exciting to hear what he has been doing. Now, any professor in AIMS, or so to say any medical college, would do three things, right? They do clinical care, patient care, they do teaching, and they do research, right? So that's a part of the job. But if you look at the topic for today, innovation to implementation, there is a fourth pillar for any medical college. And that is something which has been missing from, a lot of our lives, and which is implementation. I'll just give you an example. As a surgeon, because I do hysterectomies, I do cesarean sections. As a surgeon, I am supposed to do a surgical hand wash for 2 minutes. And a WHO guideline will tell you that you have to wash hand for 6 minutes. So a simple thing of implementation of a hand wash for 6 minutes, how many of the surgeons would actually do? So it's very easy to make guidelines, but to implement it is very difficult. And that is what is quality improvement. Sir talked about quality improvement. So improving quality of care through digital innovations, through various other innovations. So that is what I also am passionate about, and that's the fourth pillar that I have been doing, trying to improve quality of care in whatever I do through various means, whether digital, whether non-digital, whether through improvement in trying to do whatever in the areas that I work. So I think one of the most difficult areas of work is implementation, and that is what is, we try to make an effort to work on. So I think that's something that I have to, really trying to change, but that is something that we are, very far from.
Thank you so much, Aparna. And I think every time I hear you, I just get fairly inspired by, I think, how much you push yourself to do a little bit more beyond just what needs to be done in the kind of work that we do. So thanks for that, and thank you for always sparking that idea of being passionate as you kind of go along. I think in this room, and for the benefit of everybody else, but also for me, walk us through a little bit your journey. So what made you kind of think about a career in public health and becoming a doctor, and walk us through your personal journey a little bit.
Right. So I think, it's kind of, if I say, it's been very cliched, right? Anybody in the yesteryears who was kind of good at studies, kind of became doctor. So I think I became a doctor because, you're good at studies, parents thought you have to become a doctor, so I became a doctor. And honestly speaking, I was very fortunate to be guided by the right people at the right time. And I would say that, and I feel it is my responsibility to guide the next generation to the right side, in the right direction. So I would just, in that particular terms, I would say that yes, it is my responsibility to do the kind of work that I'm doing in terms of clinical care. So I come from, I had my schooling in Ranchi, which was a small, right now it's in Jharkhand, but yes, at that time and that point in time, and then I did my MBBS from BHU, and from there I moved on to Maulana Azad Medical College. And there was a time when, after that, I applied for my senior residency in AIIMS. And during my, facultyship in AIIMS, I met a mentor who told me to think about quality improvement. And like I heard one of the pitches of one of the teams who talked about waiting times, right? One of them said that there is increased waiting times in mental health clinics. So my only question would be, this is just an example. Who decides the improvement plan? And I think that is what ails the health system in this country. In the hospital, there is a waiting time of 4 hours for an ultrasound scan. And in terms of, if it's a private hospital, then maybe there is a quality team who will have some manager who's trained in, say, digital, there is a team, tech team, then there is a manager who's trained in hospital administration. But what is the input from the clinical team? And most of the time, we have policymakers, and then we have the technical team. But what is actually missing is an input from the clinical team. And we are, having been a part of a lot of policy programs, or having been a part of the team which makes policy, I've realized that as active clinicians, our involvement in policy making is limited. And that is what really pushed me that yes, even if we are doing teaching, training, and research, it is our primary responsibility, being in obstetrician, being a woman, I connect with the problems of women. And unless I take that lead, things will not change. So I think that is what really has driven me to do, to be in the public health. And I think this is what I'm going to do about it.
Thank you, Aparna. Thanks for sharing. One of the things that we do as part of the leadership journey at Women Lift Health is we ask the women to work on a passion project. We typically call it a leadership project. And the idea of that is that the women need to start thinking a little bit about what are their personal passions that they want to try and take forward. And we've had some pretty fantastic ideas that a lot of the women have taken forward. You, for one, have done pretty incredible work in the area of respectful maternity care, created resources, toolkits, trainings. So tell us a little bit about that.
Right. So I think I was really grateful to Women Lift Health because, they kind of, a lot of us here, when we start our careers in healthcare or, in the field of health, we are just pushed into it. We are not trained to be leaders, right? We are not trained to be managers. And somewhere along that line, we have to learn to handle people. So I'm really grateful that I had that opportunity in the middle of my career to do that project. But I'm sure all of you have family members who have delivered in labor rooms, have had experience of labor. And I've been always troubled that when women go into labor, especially in public hospitals, their experience of care around labor is not great. They're abused, they're not treated well. So I think this was something that I've been passionate about, and I really have started working on that. And in the last 1.5 years, I have collaborated with more than, with the Delhi government, with WHO country, and with agencies who work in respectful care. And we could take this project to more than 20 hospitals across the Delhi government, touching almost 60,000 pregnant women, so that all the delivery points have been covered. So I think this was something that has really affected me in the past, and I hope to really continue working on it. And I'm really thankful that I got this opportunity through Women Lift Health to really, take this forward.
I think what Aparna doesn't mention is that she does all of this outside of her ongoing work at AIMS, which she reached this place at 3:44 for a session at 3:45 and called me saying she's just coming out of the OT. And so I think it's really quite commendable that this is something that you do purely out of your passion, right, Aparna? And so hats off to that. We know you've done a little bit of work in digital healthcare as well. You've done some research, you've done some work outside of that. So tell maybe this group about that.
Yeah, so I think all of you are, digital health enthusiasts. So I'll share my experience with digital health. So I consider myself very tech savvy, by the way. So maybe I will fall very, very pale in front of you. But I think I believe in keeping abreast with what is happening around me. So I actually have made 2 applications for antenatal care, right? So this is available on the Google Play Store. And so when I started it, what really happened is that I wanted to ensure that WHO has made guidelines for antenatal care of pregnant women. What is happening is when you go out of, say, AIMS, or you go out of Delhi, or even in Delhi, the quality of antenatal care which is being given is not up to what is required. So what I said is that what Dr. Nikhil Tandon essentially showed is that there are standard guidelines. Why not make those guidelines and say that, okay, you are supposed to do at this stage, and why don't you do this? So this is what I did, and I put it across. So first I tested that in AIMS, then I did that in Ballabgarh, which is a CHC. Then I went down to PHC, and I went and saw whether they're able to do this. Now, what I found is that AIMS could adopt it very easily because, of course, the basic knowledge is there. But I went down to PHC and CHC and PHC. The adoption, the resistance, the the understanding of the healthcare providers, and not just ASHA or ANM, even the medical officers are unable to take it. So it is easy to say I will make a digital health innovation and provide it on a tablet, but the acceptance is so tough. But I'm still struggling with it. I've made a vernacular version of it, and I'm going to roll it out soon in Haryana. So I will be back probably with some more experience, and I do hope to make a difference, and I'm really passionate about it. I have also worked with Niti Aayog on clinical decision support during pregnancy to say that, okay, if a patient has this, you do this. But trust me, doctors are irreplaceable. The simple things of if a patient has 4 conditions, the algorithm loses it, right? If it is okay if you have diabetes, but if you have diabetes, hypertension, hypothyroidism, and IHCP, you are at a loss. So we really appreciate digital innovations, but right now I think there is, we have to probably, with the AI coming in, I'm sure we'll have better options. But my experience with digital tech is, I'm sure there has been like, it's like plus minus, but I'm still passionate, and I'm going to roll it out very soon next month with a DST project in Haryana, and I'm sure I'm going to have much more experience on that.
Thanks, Aparna. And it's reassuring to know, I guess, that we as human beings are not going to be replaced by technology anytime soon, because clearly something that we bring to the table as well. But I guess the important thing is to know how do you kind of blend it together, right? I know we have only a couple of minutes to go. So in terms of just kind of addressing this room, in terms of just advice that you would give a bunch of youth between 25 to 35 who are trying to kind of dabble with this work and understand what their future in digital health would look like, what would you say?
Right. So I think when we plan anything with digital health, first of all, please see what data are we collecting, right? We get very greedy when we are collecting data. So just curate the kind of data we are collecting. Do not collect even one single extra data. Number two, when you are on the ground, see whether you are inconveniencing people or are you actually trying to help people. That is number two. Another thing that I will say, are you eventually trying to, do not duplicate the work. The intervention that you are proposing, will it replace the existing handwritten registers or not? That's the biggest problem with the ASHA workers. So I think that is something that you have to keep in mind. That whatever intervention we are proposing, like one person said that we are going to remove papers. But at the same time, we need to say that, it has to be robust enough to be able to be integrated in the existing systems. For that, it has to, work alongside the existing system. Anything that you are going to, so we worked with Peramal in Behraj, where they said that you will be able to integrate it into the existing system. Eventually, we could not do it. So I think these are some of the problems, and also the interface that you give to people to work with, right? So you have to keep in mind the IQ of the people, the general IQ of the people. One page should have only 3 columns. Make the interface very user friendly, and it should not have too many lines. Make it just no words. It has to be infographics. So I think, and also it should avoid internet-based inputs. Make it offline. Your internet will not work in a rural setup. You do whatever you do, it will not work. And this experience is coming from working at the ground level. So all of these things, if you want a digital thing to work, it has to be off internet input. They can come to a Wi-Fi area and then it gets uploaded. So some of the things that you have to take care, do not overload. So Asha will say, एक और input आ गया, है ना, एक और intervention आ गया. So whatever, but you say, ये पिछला चीज हटाएगा. Only then we need to plan those. So whenever you're planning something new, think well before you plan something, that you have to ease her. You have to ease her workload and not increase her workload. Yeah.
Thank you, Aparna. I think when I was asked by Pallavi and others at PATH to talk about women leadership in public health, I grappled with how do we use this forum and realize what's a better way to talk about women leadership in public health than to bring an actual woman who works in public health and does the incredible work that she does. So thank you for your time, Aparna.
Just take 1 minute.
Yes.
So I'll just say that what Women Lift has really contributed is, there is a saying that what got you till here will not take you forward, right? I have been always the star student until I actually had some of the leadership journeys. So it's like, आपने अगर पढ़ाई कर लिया, आप achieve कर लोगे. But it is actually for all of you also. Sometimes till you are at a level, you do hard work, you achieve stuff. But beyond a certain level, there are other skills, other leadership skills that you really, really need. You networking karna hai, you need to bend backwards. It is okay to say sorry. It is okay to go bend backwards. So sometimes it's not just talent, right? Sometimes it is connections. So we need to accept all that, and for that I would like to thank Women Lift Health.
Thank
Right.
you.
Thank you very much.
And I'm going to shamelessly plug our applications. We have applications opening on the 15th of August. I don't know if this room actually qualifies, but if you are someone who identifies as a woman, are working in the area of public health, and consider yourself as a mid to senior level person, then do apply and go through some of our work. But thank you so much for your time and patience.
Can we ask one question?
Sure.
Great. So, in terms of women lift, so women leadership really matters. But while we are talking about women leadership, as a leader myself, I feel that there is a lack of education that exists in men in accepting women leaders or having a seat at the table. So how do you think that while we're empowering women to become leaders, how do we educate the men to accept that?
So I think it is difficult. I completely echo your views that while it is, it is for us to, say that we need skills, we need communication, we need networking, it is still very difficult to advance beyond a level. And I completely echo your thoughts. Like I said, what got you till here will not take you forward. So I think I think there are organizations like Women Lift Health, and there are other organizations who make it a company policy, to have women in leadership positions. But also, even Women Lift Health and other organizations, they talk about, they bring in men who are into this kind of a thought process. But I feel that it is all about advocacy, and also women in leadership positions who have done well, and men who support the cause that they have to talk about. But there will always be those 5 and 10% of people who will not accept it. We have to ignore that and move on. And I've always felt that there is room for negotiation. There is always room for negotiation. But beyond a point, when you see a failed cause, leave it and move on. This is what I've always felt. But yes, and I agree with you that there is always a resistance, but when you give results, after a point, you can always proceed. But as I say, 10%, you have to leave and move on.
Thank you very much.
There's a question there, yeah.
I think this will be the last question. Yes.
Good evening, ma'am. I'm Dr. Vanshika Gupta. You talked about RMC and the practice of RMC in 20 hospitals across Delhi. I think we all can agree that Delhi hospitals, or the working in Delhi hospitals, even the staff nurses, the work culture is pretty much better than if you go away from Delhi. Do we agree on that?
Yeah, okay. Let's have the question first.
All right. So why I have put this question is because I have worked in UP, and in UP, has been doing nurse mentoring program, which encompasses RMC plus nurse mentoring on all 6 cycles.
Yes.
Yeah.
Lakshya cycles.
Sorry?
Lakshya cycles.
Lakshya cycles, yeah. So my question is, I have absolutely seen no RMC being practiced there.
Yeah.
And can you please share your experiences how that can be inculcated there?
Yeah.
Because I know that mentoring them, telling them, there is something which we are lacking or they just don't want, but there's a huge gap.
Yes.
Which I don't know how to
No, I
address.
completely agree, and that is why I feel there has to be a leadership coming in from clinicians. What we do is that I am from AIMS. I am a core obstetrician from labor room myself, right? I am not a quality person, okay? And I have my colleagues, and I conduct a multi-professional workshop in a busy labor room, and I go there and I conduct a full day workshop on RMC, right? So which includes parts on communication, which includes a parts on patient experience. And I say that I do it in my labor room. So it is actually role modeling that it is possible in a busy labor room where I work So it's possible for you to do. Telling them, right, coming from a quality manager, it does not make an impact. Right? So we have seen, so it's not that when you say that the care in Delhi is much better, I think you're quite mistaken.
No,
And
why?
what I'm saying is, we have gone to labor rooms in Delhi itself, within the district hospitals of Delhi. So Delhi has a varied 44 delivery points, which can vary from medical colleges to district hospitals. So we have seen the kind of, the behavior. So they say that shouting is okay, slapping is not. Okay, so मैडम चिल्ला रही है पेशेंट तो हम भी तो डांटेंगे ना, है ना, क्या कर रही हो रानी, चुप रहो ना. I mean, all of this is fine for them. So it is the culture, it is how we have grown up, how they have grown up seeing. So everywhere it is the same. But somewhere we have to start. So if we have conducted 15 workshops in the last 1 year, we have seen each and every one of them getting shocked at what we do. And it is not just, it's Delhi.
No, why I compared Delhi and the other state is because the population in Delhi compared to other states, example UP, there is more awareness among the people.
Yes.
About their rights. But you go to UP, you go to further in the UP districts.
I understand.
You will see the shift in power dynamics.
Right.
You will, because most of the people who are coming to public infrastructures, public systems, they are all rural-based, labor-class people.
But they are still, they deserve respect.
Exactly.
And I completely agree with you, but there is a need. So we are moving on with the Foxy to other states also. We would definitely want to do what we can do, but I have limited time to expand this, but we are trying to move on to things, and there are other organizations who are working on it, but this is the need of the hour, and this is something that we need to do, and I know we are running short of time. So thank you very much. Yeah.